So I'm going to introduce to you Dr. Nathan Hudding. He's an associate professor at the Han University of Applied Sciences in the Netherlands. He also works as a physiotherapist and manual therapist in private practice. His current research topics include long-term conditions, musculoskeletal conditions, self-management, patient-centered care, and shared decision-making, occupational health, and work-focused healthcare. He's a board member of the Dutch Association for Manual Therapy, is a member organization, he is the member organization delegate of the Netherlands to the International Federation of Orthopedic and Manipulative Physical Therapists, and is a member of the Scientific College of Physical Therapy of the Royal Dutch Society of Physical Therapy. He's also an associate editor of BMC Musculoskeletal Disorders and a member of the International Advisory Board of Musculoskeletal Science and Practice. Nathan is also a member of the World Physiotherapy 2023 Congress Program Committee. So welcome, Dr. Hudding.
So, good morning and thank you for the kind introduction. It's also my first San Diego Pain Summit, so I'm really excited to be here. So Rajam, I also want to thank you for having me here. I did present an online presentation 2 years ago, but that's also totally different than being here physically present. That presentation 2 years ago was also about self-management, and there's a little overlap in the two presentations, about 10%. But I think that's not a problem. But if you want to learn more about the topic, you can also go on YouTube and watch that previous presentation, of course. So, let's go ahead. Maybe it's 45 minutes here. Maybe it's going too thick. Otherwise, I have my own timer right here to keep it all on time. So we're going to talk about person-focused self-management support and people with musculoskeletal pain conditions. And of course, it's also broader applicable, I guess. So I come from the Netherlands, nice country. Next year, the ISP conference will be in Amsterdam. So if you're interested in pain, then you can come and visit the Netherlands, Amsterdam. It's always nice weather, especially in the summer, July, August, when that conference will be. So then you will see this sunny weather in the Netherlands. So I focused on musculoskeletal conditions, so you all know because you are familiar with this, so they cause pain and also reduce function. And of course you also know that they have a multifactorial origin, and we also talk about the biopsychosocial model in a few minutes. And these conditions occur in all ages, so it's not only older people who have these conditions, also children, but also middle-aged people. And often they are also work-related. And that means also that with the increasing prevalence, it also leads to high costs for society. Not only the direct costs of healthcare, but also the indirect costs of being absent or presenteeism, for example, at work. And I'm sure you know these recommendations that were published in literature the past few years. So you see, for example, here, that pain should be patient-centered, care should be patient-centered. This is also what I will be talking about today. But also assess the psychosocial factors, all those recommendations. So I made a kind of an overview, a brief overview. So my conclusion is that pain should be patient-centered, should include a biopsychosocial perspective, should include shared decision-making, education, and also self-management support. And also this morning, exercise was mentioned, and I also believe that in such an approach, also in a self-management approach, exercise is really a cornerstone. So I really agree that it's very important. Of course, it's about self-management, so please self-manage yourself. So if you want to stand up, walk a little bit, drink a little bit, go ahead. I will do the same. So there are all those guidelines and recommendations. And I'm a physiotherapist from background, so it's also a little bit focused on physical therapy sometimes here in this presentation. But it was found that many physical therapists seem not to follow those evidence-based guidelines. And there is a considerable scope to increase the use of recommended treatments. So there is something we can work on. And I hope that this presentation will also contribute a little bit to that conclusion and to improve our practice. So just from literature, some characteristics of patient-centered care. So regard the patient as a person, include that biopsychosocial perspective. It's about sharing power responsibility, therapeutic alliance, individualized treatment. We also heard a little bit about that this morning. Patient-defined goals, very important, because also as physiotherapists we're used to make our own goals for our patients, I guess, and also include the patient in the decision-making process. So the biopsychosocial model, and we all know this model, and maybe this is a good audience because you're all familiar with this model, and I hope you also apply this in practice. But that's not always the case. I'll show you some examples of that from literature. But what I think is very important is don't only look at causes from that biopsychosocial perspective. So people have some complaints, and of course there are biopsychosocial causes of complaints, but every complaint also have biopsychosocial consequences. So also psychological and also social consequences. And that's very important because as physiotherapists, I think we're also neglecting those causes because we maybe don't know how we should handle those psychosocial and psychological causes. So we did some research, some qualitative research in the Netherlands about people with low back pain, but we asked physical therapists and also exercise therapists, it's a profession we have in the Netherlands, about it. And some highlights here. So we found that the therapist mainly provided patient education rather than self-management support. And later in this presentation, I will show you some of the differences. And also we found that these therapists mainly focus on the biomechanical factors of the condition. Yes, and that's what happens a lot. And also that the important general self-management skills were not addressed sufficiently. And the respondents had needs, so that's good, I guess. And in the other study, also we found the same results, that they do not integrate those general self-management skills. And also that they experience integrating self-management into their practice as difficult. And also it was not working well for all patients. And one of the barriers therapists experienced were the patient expectations. And I will also come back to that in a few slides. Some of the needs that we found in this study were knowledge about self-management and providing self-management support, and also tools and methods to facilitate self-management in patients. And that included also the latest scientific evidence about self-management, training in conversation skills, and also methods to facilitate behavior change, and also some digital tools. And in fact, we are doing another project now, and then really we do also have a hands-on course focused on training that conversation skills and also to facilitate behavior change, because that's very important. It's not only about knowledge, but also really about practice and the skills. A more recent study we conducted in patients with arm, neck, shoulder complaints. In that study we found also that patients frequently ignored the advice. And that's good to know, because why do patients ignore the advices of the physical therapist? I think that we should blame the physical therapist obviously for that, because maybe, it should be patient-centered, individualized, and maybe when patients ignore their advices, something went wrong in that communication, I guess. And also we found that also in this study, therapists needed skills with regard to behavior change and coaching. And also in this study, physical therapists found it difficult to acknowledge the patient as an expert. But patients are experts on their own problems, on their own complaints, on their own body, of course. And again, we found that physical therapists found it difficult to apply proper conversation skills. And they wanted to learn more about engaging in meaningful conversations. So about assessing therapeutic goals, provide adequate feedback, and asking critical questions, etc. And these therapists stated that those problem-solving skills were very important patient skills, but it was unclear how they could improve those problem-solving skills. They didn't know how to do that. And also, so these general self-management skills, which I will be addressing in a few minutes, were not explicitly mentioned. So they are not really aware of the theories and the self-management skills. But they did address some of these general self-management skills, but they didn't know maybe themselves. And that was obtaining support at the workplace. It can be on the creating partnerships and listening to one's body and increasing awareness which can be under the category self-monitoring from the general self-management skills. So also again, providing coaching and behavior change and self-management support. They did do that, but they really found that difficult and they needed additional skills. So these were 2 studies conducted in the Netherlands, but this is not a problem only in the Netherlands. So this was impressed right now, this study, a very nice study, conducted in New Zealand about the physiotherapist's attitudes and beliefs about self-management as part of the management for low back pain. Again, low back pain, but it's generally the same in other musculoskeletal conditions. So also here, the physical therapists understood the importance of self-management. But again, they lacked the understanding of what self-management entails. And also, again, a few participants only could describe those general self-management skills. So that's yeah, I think, yeah, we find it important as physiotherapists, but we don't really know how to provide self-management support. And again, here also, instead, it was more patient education, for example, and also giving an exercise program that was labeled as self-management and self-management support. And the last sentence is also that successful implementation of self-management was measured by adherence, and especially for adhering to their exercise program. And we will also see that adherence is not really a good way to measure self-management. So you should measure, of course, the general self-management skills, like obtaining support, self-monitoring, problem-solving skills. And this is also kind of striking. So a very recent study which found, this is conducted in patients, that self-management strategies were developed by patients to the physical and emotional toll, attempting to assess services, and often these strategies were accompanied by partial or complete withdrawal from the healthcare system. And that's not a good thing, of course, if you want to provide self-management support. People should be in the healthcare system. So integrating self-management support into the routine pain management is very important. And also this study found a lack of psychosocial assessment and influence. So people still use that biomechanical health model. Also here, so when we look at the biopsychosocial model, physiotherapists are not that well in estimating the psychosocial factors. But also, physiotherapists lack confidence in assessing those psychosocial factors. So that's very important. So if we don't have the confidence and do not have the skills, yeah, it will be very difficult to assess these factors, of course. But we know that many people still look at their complaints by a biomedical perspective. So they consider their condition to be persist or recur because of biomechanical or structural reasons, so machines that can be broken. And that's also what I see in my clinical practice often. And here, maybe it's a little small, but about 90% of the patients said that these understandings came from the healthcare providers. So healthcare providers play a very important role in these beliefs that patients still have. It's not too good quality, but it's also here that those beliefs that are not appropriate. So it's about those myths that people have, and you see the people right here. But the myths come from social media, for example, from the culture, from their own experiences, from the society, from their peers, but also here from healthcare providers. And this quotation is very important. We need to address the upstream development of myth at the source and not at the downstream. So we should really focus on these sources of myths, including healthcare practitioners, to change the society, for example. And also in guidelines, it's not always clear what we should address with regard to those biopsychosocial factors. So when guidelines do not provide clear recommendations on how to use the biopsychosocial model in practice, then of course also clinicians have some difficulties with appropriate using the biopsychosocial model. And this study found some barriers with regard to implementing the biopsychosocial model. So it was about knowledge, skills, and attitudes. Now, we can work about that. But also about the environmental contexts and resources. So we also heard this morning about Our treatment, so in the Netherlands we have more or less 30 minutes of treatment. And so one of the barriers is insufficient time, for example, to use the biopsychosocial model and especially implementing the psychological and social factors. Role clarity is also an important barrier. What is our role as physical therapists? Should we assess these psychological and social determinants? And if we found some important things, can we address them or can we only refer patients? And then we see again confidence as a barrier and also the patient expectations. So I believe that we are in a kind of vicious circle because patients have requests and expectations based on their past experiences and beliefs. And we saw that these beliefs often come from us, healthcare providers, because many clinicians still have that biomedical orientated approach. And that is also, we found, a very important barrier because patients expect that. And this barrier might prevent physiotherapists from changing their practice because we also want to fulfill the expectation of the patients, of course. And this could also reinforce inaccurate patient beliefs and expectations. So we need to change this. If there is this here, please, you can make pictures, but don't put them on the internet right now. So we have some few recommendations of changing this. So it's really about breaking that vicious circle. And we think that optimizing networking is very important, enhancing knowledge and skills of the clinicians, but also improving those clinical practice guidelines, and then also educate society, because that's also important, but that's really downstream, but upstream is really enhancing knowledge and skills of practitioners. So that brings us more focus on patient-centered care for people with musculoskeletal conditions. And this journey started at the World Physiotherapy Conference, the online conference in 2021, in which I was chairing this nice focus symposium with these nice colleagues. And afterwards we wrote this article, Patient-Centered Care and Musculoskeletal Practice, Key Elements to Support Clinicians to Focus on the Person. And you can, of course, download that. It's freely available on the internet. But then we wrote this article. So, of course, I want to acknowledge JP, Lisa, Maxi, and Oceano for working with me on this paper, Person-Centered Care for Musculoskeletal Pain, Putting Principles into Practice. And I'm not presenting it today, but we also have a nice case study, I think 4 pages, so about how you can use this approach in practice and can give you some ideas how to do so. So this is a kind of, we call it kind of a framework. I don't know if it's really a framework, but it's some guidance to implement a person-centered or person-focused. We used to call it person-focused, and we changed it back to person-centered. But we wanted to keep the word person-focused here in person-focused communication. So there are 3 really key elements of this framework. So it's a biopsychosocial understanding of the person experience, person-focused communication, and supported self-management. And then we have 3 kind of phases. So we have the identification and goal-setting phase, which consists of identification, shared decision-making, and goal-setting. The second phase is the coaching to self-management phase, which includes addressing those general self-management skills. I will give examples later, and also addressing specific knowledge, skills, and tools, including those skills and tools with regard to overcoming barriers, because all patients will experience barriers. This is very important to support them to overcoming these barriers. And then we have an evaluation phase with evaluation of the goals, planning for the future, and making a follow-up plan. And of course, you can also mix these phases in between because, of course, you can also have a new identification and goal-setting phase after a coaching to self-management phase, for example. And you do evaluation in between when you are working with a patient, for example. And one overarching theme is the therapeutic relationship, because this is very important. I think we all agree on that. This is one of the key elements of what we do. So that's a very important element also in this framework. And I know Maxi was here a few years ago at this conference. It's really nice to work with her as well. And she did a lot of work in this area. So building the therapeutic relationships. And this is the definition in the physiotherapy context. So let's see, the safe relational space and effective bond between patient and practitioner developed both professionally and personally when establishing connections and engaging in the collaborative work of physiotherapy. And I think that personally aspect is also very, very important. I'll give an example on one of the next slides. And we know that this therapeutic relationship is very important. So it results in improved clinical outcomes, higher satisfaction with services, and also better adherence with treatment plans. So this comes from Maxi's work, so about establishing meaningful connections. So that means consciously being present, receptive, committed, and genuine. And meaningful connections are those in which the participants feel they have been seen, heard, and appreciated. And also, again, can be professional and personal in nature. And I think also we need some time to develop this, of course. So we cannot rush into our treatment, and because then we cannot really build a meaningful connection, I guess. And these connections do not happen by coincidence. So we need to make an effort and intentionally develop those meaningful connections with our patients. And that, of course, can be challenging because patients also have different expectations. Maybe your skills are not up to date with regard to building these connections. So that brings us to the framework that Maxi has developed. So it's about three components. So the first one is acknowledge the individual. So it's about meeting as an equal, validate the patient experiences, and also, again, individualize the treatment approaches. So some examples: sit at the patient's level, very easy. Affirm expressions of emotions or personal disclosures, and also adapt home programs by considering the patient's unique circumstances. So every patient is unique, and that's, I think you all know that. So maybe you are an easy audience. Sometimes it's more difficult to engage people in these kind of talks, but yeah, I think you all agree with me on that. Then we have give of self, inside the interaction and outside the interaction. So share a part of your life or experience as appropriate, and also speak with patients, other care providers. So when I started my journey on self-management a few years ago, I did a PhD. I started that in 2012 on self-management, and that was my first experience with self-management. And afterwards, a few years ago, I went to the Chronic Self-Management Resource Center in Palo Alto, and I followed the course, the self-management master training with Kate Lorick. And I learned a lot of that. It's a 1-week course, so if you want to learn more about self-management, I think that's a good starting point to follow that course. And then 2 years ago, and this is also an example of share a little bit of your life and your experiences as appropriate. And I also share this experience the last few months with my patients. And I've never shared it on a conference, so this is the first time. It's not that exciting. But since 2 years, I also suffer from pain. So I have persistent pain, and so I have a herniated disc, and I have very difficulties with sitting. So if you see me a little bit walking or something like that, flying is also difficult. Driving a car is very, very difficult. But I was able to self-manage, for example, and I still have pain, but I'm able to manage my pain and to have a nice life. I think exercise is very important. I try to exercise 5-6 times a week. Sorry, a day is a little bit late. Yeah, sorry. Yeah. So the problem is here, the gym only opens at 8, so it was difficult to go to the gym before the conference, so I need to go this afternoon. But as an example, I also, I see many people with leg pain based on the herniated disc, for example, or other causes. And then I think sometimes in some patients, I feel it's appropriate to share some of my own experiences. And that's an example that I use also in my own practice. I only practice 1 day a week with patients, but I really love that. So don't be afraid, and also share your own experiences. People really appreciate that, I guess. And of course, speaking with the patient, other care providers, I think that we all hopefully do that if appropriate. And then use the body as a pivot point, because really the body is, people also expect us to talk about the body and to do something with the body. And we can really use that. So clarifying physical problems and solution, facilitate the patient's connection to the body, and also use touch to bridge a gap. So all those hands-on treatment can also be used in this manner. We can connect with people through our hands, and we're one of the few professions that can do that, I guess. Sorry, wrong side. So examples provide clear explanations of assessment findings, and also make sure the patient understands that. For example, the teach-back method you can use to understand if the people correctly understood what you were talking about and explained. Cue patients to their bodies to develop awareness, and also carefully handle the patient's affected body region. In the presentation online 2 years ago, I gave some more extensive information about shared decision-making, so I'll do it very shortly now. It's about communicating together with the patient, discussion with the patient, sharing information, obtain a joint understanding, and then also empower the patient, of course. It's very important. Also in self-management, empowerment, one of the key issues, I guess. And then, of course, eventually you need to make a decision, or not you, the patient needs to make a decision. So here you see some shared decision-making steps. So there are always more choices. There's not only one treatment method. And doing nothing is also a possibility. So explain that to the patient also what will happen if we don't treat, for example. And then invite the patient to partner with you, because not always patients expect that. Maybe they just used to a practitioner who provides a treatment plan, so do this, do that, etc. But yeah, so it can be difficult. And if a patient don't want this approach, it's also fine. Eh? Then we do an old school approach. It's also possible. So describe the nature of the problem, elicit the patient's expectations, explain the various options and the harms and benefits of each options, explore if the patient is ready to make a decision. If not, please, why is the patient not ready, and address that, of course, and then agree on the course of action and implement the chosen treatment. Follow up, obviously, and then also evaluate the outcomes and assess next steps. So self-management. I have two definitions over here. So the first one is the older one from Barlow. The ability to manage symptoms, treatment, physical and psychosocial consequences, and lifestyle changes inherent in living with a chronic condition. And the second one is interventions that aim to equip patients with skills that allow them to actively participate in and take responsibility for managing their persistent condition so they can function optimally. And I think that's a nice one, because I think optimal functioning is very important. It's not perfect functioning. I'm not able to function perfectly, but I think it's fairly optimal. And also it's very important to take the responsibility for their own complaint and for the management of their complaint. I think that's very important. And of course, patients need to be equipped with skills and knowledge, because otherwise they don't do that. I was lucky that I had some knowledge about self-management, and that went well, but patients maybe do not have those skills. I doubt if you have those skills. I saw nobody standing up, so maybe, but I drink a little bit of water. So these definitions are important. Oh, sorry. Yeah, oh, it's slow. So this book is also from Kate Lurick et al. And I want to show you here because there are many components of self-management. And we saw previously that those physical therapists mainly focus on the biomechanical aspects. But here you see also finding resources, understanding and managing symptoms and emotions. It's all chapters in this book, nice book. Use your mind to manage symptoms, being physically active, exercise to make life easier, freedom and safety, healthy eating, communicating with family, friends and healthcare providers, and managing your treatment, decisions and medications. So it's important that we address this broad variety of topics and not only focus on only exercise, for example, as we often apparently do. So this article we wrote in 2019, and I think this is the important quote. So physical therapists, but also other healthcare providers, should use a self-management approach to individualized physical therapy treatment for patients with persistent musculoskeletal disorders whenever possible. And I believe it's always possible. So I think this approach, we should use this approach in every patient. And then, of course, we can also use it not only in people with persistent complaints, but also in acute and also subacute problems. Because it's rather strange that people with low back pain person with low back pain comes to you with, I think, 3 or 4 weeks complaints, and then you do a whole different approach than to somebody who has experiencing low back pain for 3 months. And there is also or 6 months or 7 months. And there's also, of course, a chance that that person who comes to you with acute low back pain will develop persistent low back pain. And then it's very, very strange that after a few months you will use a different approach. So incorporate that self-management approach directly in every patient. And of course, you can combine it with different approaches. So I'm not opposite to hands-on treatments, but use it appropriately and to complement such a self-management approach. That brings us to self-management support. This is the definition that I found. So self-management support is the help given to people with chronic, maybe also other conditions, that enables them to manage their health on a day-to-day basis. And self-management support can help and inspire people to learn more about their conditions and to take an active role in their healthcare. So really about that empowerment, taking an active role, of course, in their management of their complaints. So it's about compassionate, patient-centered care, involving the whole treatment team, and focus also on prevention and management. So prevention is also very important. Therefore, exercise is also very important. And also, again, involving the patient in the goal-setting process, and also customize again, education and skills training. And of course, some of these self-management programs, they have some general education and skills training, of course. But in our support that we can provide to our patients, we should really customize our support. And also making referrals to existing community-based resources, and also follow up with patients is very important. So it has some benefits, of course. So with regard to the patients, literature says that there are significant gains in health status, better quality of life, better outcomes, and also a positive impact on attitudes. With regard to the service, a reduced use of GP consultations, reduced hospital admissions, and services more joined up, and it's also more cost effective. And I also think I want to emphasize that for me, self-management is not about costs. It's just about delivering appropriate care. And then potentially it can lower costs, and that's nice added benefit, I guess. And with regard to the clinician, it's also about more meaningful conversations, greater impact, and also increased satisfaction. So again, this framework again, so we'll just shortly touch the identification and goal setting phase. So it's really about identifying the person's experiences, ideas, and beliefs. That's a starting point. So you really need to have those things clear. And then also evaluate the person's attitude, self-efficacy, social influence, knowledge, and skills. I will talk about that later in the model that we use for behavior change. And then it's important also to address those general self-management skills. And I will show you examples, because also in the studies that and also in that New Zealand study, those general self-management skills are often neglected by physical therapists. We focus on exercises and treatment plan and exercise prescription, those kind of things, but forget all especially the social aspects and the psychological aspects, because we do not feel confident, I guess, in addressing that. And then also evaluate the expectations, also openness towards self-management. Again, the same as for shared decision-making. If a patient is not ready to use that approach, if a patient is not ready to use a self-management approach, don't use it at the beginning. Just do a normal approach. And of course, I think the patient will be open after a while, and then you can also use that self-management, or you can use parts of that self-management approach. And patients, of course, should also be ready to change. But I think you already know that. So, this is what we call the self-management identification tool. What we're also working on is a kind of questionnaire about self-management and self-management skills that can be used in people with musculoskeletal conditions. It's not finished yet, but I think it's also an important work that we are currently working on. But this is the self-management identification tool, and that's something we can use with our patients. And we can use it in all these 3 phases. So you can use it in the identification and goal setting phase to identify problems, for example, or barriers. We can use it in the coaching phase because we can focus on those different aspects. I will show you them later. And we can also evaluate those same aspects, of course. So in the green, in the inner circle, these are the general self-management skills, the problem-solving skills. It's about obtaining support, working together, goal setting, action planning, monitoring changes, self-tailoring, making decisions, and using resources. And again, these are often neglected by my colleagues. So these are very important that we don't forget to address and provide support with regard to these themes. And then we have more specific topics. So really broad variety, role and management, dealing with problems, managing exacerbations, expressing needs, lifestyle, social contracts, hobbies, work participation, emotions, all more specific topics. And these are also important. But as physical therapists, I think we are quite good in working on these kind of topics. So often we just forget about these green, important general self-management skills, and we only focus on these more specific topics. But don't forget those green skills. And then it's also about behavior change. So we use the ASE model, attitude, self-efficacy, social influence model, to obtain a behavior change. So we start with the attitude, self-efficacy, and social influence. And in self-management, self-efficacy is very important. So also when patients make an action plan, also from the program from Lorik, you ask people, how confident are you that you can execute your action plan? And if they have less than, on a scale from 0 to 10, less than 7 in confidence, you ask them to rewrite the plan so that they are likely to succeed in that plan. Because positive experiences are very important. So based on the attitude, self-efficacy, and social influence, patients have an intention to work on behavior change, and they start to make an action plan. And then, of course, we can support them because patients will experience barriers, and then, of course, knowledge and skills are very important. So we can support them with obtaining that knowledge and skills that they need for their behavior change. And we can also address barriers, and we can support them by overcoming these kind of barriers. And then if you do a good job together with the patient, then eventually they will show, hopefully, a kind of self-management behavior. Now, again, this comes from literature. It's really about problem-solving, decision-making, using resources, partnership with the healthcare provider, and also goal setting, for example. And also, again, individually defined reciprocal partnership. Those kind of things are very important. And it's a lifetime task. So, as I mentioned before, some differences between patient education and self-management support. So, patient education provides information and teaches technical disease-related skills, as opposed to self-management, which teaches skills on how to act on problems. So the skills that you need for self-management also, you can use them more broader, because if you have those skills, you can use them for a knee problem, but when you get a shoulder problem, you can also use those skills. If you get diabetes, you can also use a lot of these skills again. So patient educations, the problems covered are mostly widespread, common problems related to a specific disease, while in self-management, the problems covered are identified by the patient. And again, the difference here, patient education, disease-specific, and offers information and technical skills related to the disease, while self-management focuses on problem-solving skills, as mentioned before, that are relevant to the consequences of chronic conditions in general. And patient education is based on the underlying theory that disease-specific knowledge creates behavior change, which in turn provides better outcomes, while self-management is based on the theory that greater patient confidence in their capacity to make life improvement changes yield better clinical outcomes. So it's about self-efficacy. And then also the goal is compliance in patient education. So also I refer to that New Zealand study. It's not about compliance. If you only measure compliance, you don't measure self-management, because in self-management the goal is increased self-efficacy and improved clinical outcomes. So, what I showed you was just the opinion of me and my co-authors, of course, in which we also used existing literature. So it's also good to know about some other models and other work that has been done in the past few years. So Kongshit et al. Also worked on this, on self-management for low back pain. It was published in the Brazilian journal Physiotherapy. So, and they also have some kind of, I think this is rather nice, because you see here time, clinical training, compassion and respect, and physical facilities. That's more focused on the clinician. And I know time is often a barrier for incorporating such a self-management approach. And then they also have some different phases. So the planning phase. So again, let value-based goals direct care, make shared decisions, and define readiness to change. And then in the delivery phase, they have 4 kind of topics. So help patients make sense of symptoms, teach problem-solving skills, set patients up for successful experiences. So here you see the importance of positivity and successful experiences, and also provide tools to manage pain and emotions. And then also an evaluation phase. So, and then the goal, of course, is autonomy, self-efficacy, and also a healthy lifestyle. Here you see another model, and I just included this one to emphasize the importance of the social environment. And I was presenting on a conference in London a few months ago, and then somebody also asked, why is it called self-management? Should we call it together management or something like that? Because not only the patient, it's also the social environment and the people around you. So here you see also those informal caregivers, the partner, friends and peers and family were very important, and also should be part in one way or another in such a self-management approach, depending on patient preferences, etc. So this is very important that we acknowledge that it's not only about the person with pain, but also about the social environment. And we believe that social cultural perspective is also very important, because here you see in the middle the patient and clinician in the person-centered collaborative approach. And then, of course, you see some discussion and alignment here in green, and then it's about the needs, expectations, beliefs, knowledge, and skills. We already talked about that, I guess. But then also, a focus on the whole person is very important. So it's also about those life goals, social functioning, economic functioning, emotional functioning, and spiritual functioning. And that is also often neglected. So this image gives an overview of that we should not forget to focus on the whole person. So this is one of the final slides. So this is the older model, the 5A model, which is about also about the personal action plan. So action planning is a very important component in every self-management approach. And then the first phase is assessing phase. So assess beliefs, behavior, and knowledge. Then advise, so provide specific information about health risks and benefits of change. Then agree, so collaboratively set goals based on the patient's interests and confidence in the ability to change their behavior. So you see again the patient's interests, so it's really person-focused, individualized, and again also people should be confident in that they can change and they want to change their behavior, of course. And then assist, so that's more or less the self-management support, so identify those personal barriers. Again, these barriers are very important to address. And then also strategies, problem-solving techniques, and also social and environmental support. And then also make patients preparing for the future, so also arrange, that's the last phase, so make also specify a plan for the follow-up, so visits, phone calls, and reminders. So that's also good to incorporate, so don't... If a patient, yes, normally I just set some appointments or phone appointments with the patient so that I will follow up with them and not say bye-bye and I never see them again. So in the self-managed approach, you also specify a plan for follow-up. So to conclude, I think we should use a person-centered approach, and that really includes that biopsychosocial understanding. So that's a very important model, and I think we will definitely hear more about that model also on this conference. And then also shared decision making is an important component, and then also coaching to self-management. And I hope that with the framework that I have presented, you have some guidance how you could use and incorporate such an approach in your practice. So thank you for your attention and enjoy the rest of the conference.
It's fun to hear it in person instead of having to be online. Okay, first question. Come on up there.
Hi, Nathan, Laura. I'm going to try and get through this whilst retaining my ability to breathe.
Okay, you remove your mask maybe when you ask a question.
No, it's fine.
I don't think he can hear you very well.
I was just, you mentioned, I think the supported self-management model is brilliant. You know, this really ticks a lot of my biases. The question that I have is, what work are we doing on assessing the culture and environment and structure, so I'm going there again, of the system that the clinicians who are being recommended to attain all of these skills and do all of this work, what are we doing to change that environment? And do you think the current traditional design of MSK practice is sort of fits with these recommendations?
Oh, that's a very good question, and I don't know if I have the correct answer, because I think no system is perfect, and the system as we have in the Netherlands is based on sessions. So we have, dependent on the insurance of the patient, we have 9 or 15 or 12 sessions, and that's always difficult to fit in a self-management approach in this session model. And on the other hand, we also know there are also some studies done with another kind of approach, more product approach, so that the clinician just gets €300 for a whole approach, and that maybe on the first side you think that could work better, but then also there is a kind of incentive to not provide that much care, because the less care you provide, the more money you will earn per hour, for example. So I think that both models have advantages and disadvantages, and I think really it should be in a higher level. People should think about it. Politics, for example. So because many people have chronic conditions, persistent pain, for example. So I think we need maybe a whole new model, and I also think that. Because I really think that incorporating such an approach in our normal, regular care is very important. But on the other hand, some of those self-management group sessions can also be beneficial. So we should use a kind of intermediate model, I guess. But also, but I want to emphasize that if you have half an hour with a patient, you can use elements of such an approach. Because I also believe that we spend a lot of time chatting with our patients while they are doing exercises or while you do hands-on treatment about all kinds of stuff, but we can also use that time to address these kind of self-management topics, I guess. So but I think, it's difficult, the systems, but yeah, thanks.
All right, Kathleen?
So kind of as a follow-up, that's kind of addressing the clinicians, but our real problem is nobody knows how to do it properly, right? And so we're not getting it into the education systems, which is, I think, where you really have to make a change. I mean, we've had this whole thing with pain management for a long time, not getting it into education. We're starting to make a change on a slow and steady pace, and getting more and more about the science. I'm wondering what you think is going to be necessary to not only get it into physical therapy and occupational therapy, and but really this should go into all healthcare entry-level healthcare professions, right? Because we should all be working under the same mode. All the pain strategies across all the countries, that's their number one thing. We need self-management, but no one now knows how to do it. And we're not training the next generation to do that. So what are your thoughts on how we do that?
Yeah, it's a real challenge, and I want to refer to the biopsychosocial model, which exists for decades, and still we have problems with incorporated in our practice. So I don't think that we can change this in a few years, and I think the educational programs play a very important role, because those new graduates are the healthcare professionals of the future. So that gives me some hope that if we incorporate such an approach in those educational programs, that hopefully in 10, 20 years, those clinicians are working, and then we can change the model. But we have such a huge of workforce that has studied decades ago, and they are not familiar with this model. So that is also a very important problem. So I think that slide that I showed you with the colors, so also educating society, also changing the clinical practice guidelines. I think we should work on really on all those elements to change it. And also, it was also including so working together and cooperation between practitioners, because it's also, yeah, I know a lot of examples that the GP tells a whole different story than the physical therapist, for example, and patients do not understand that. So I agree this is a real big challenge, and it's difficult, but also I also think start small. So start in your own practice, start in your own country, start in your own profession, and then try to cooperate. But yeah, it is difficult, and yeah, but I hope that's I think really the education programs for the future have an important role. So.
All right, and then we have a question from the online participant.
Shan asks, I'm interested in this action plan concept. What are Nathan's suggestions for the best way to structure this for a patient and share it with them? Is it written down, electronic? Is the patient expected to write it down? And if it is a document, is it interactive, and does it or can it change over time?
Yeah, I think it's important to do that face-to-face with a patient. So you interact with the patient, and then you make some action plan with the patient. And then, of course, you need to provide some support. So you have to ask some questions, and also address those barriers, because people can make a nice action plan. Of course, you also know about those SMART goals, which, yeah, have also some disadvantages, perhaps. But that is important to know what people are going to do. But the nice thing is what I also heard this morning with regard to exercise is that it should something that people really want and enjoy. Also with regard to exercise, for example. So if you want to make an action plan on exercise, you can support people with choosing the exercise components that they really like. And patients do not always get that, because I have lots of examples that patients want to exercise and ask me, what is the best exercise for me? And I always really say, yeah, what you like, what do you love to do? And then, of course, you need to work together with this patient to make that more smart, and also set some goals, so when, how, etc. But I also want to refer you to my presentation 2 years ago. I provide some specific steps with regard to action planning in that presentation.
And that presentation is available online. Okay, let's have one more question from in the room. Oh, at the microphone.
Thank you for that. I thought it was really interesting that many times self-management comes out of necessity rather than something that's been presented to the patient as something that's beneficial to them. And I was curious if we knew anything about patients' perspective on so-called self-management, whether they see that as a sort of discounting the medical system taking care of them, or if they see it positively. I was just curious, what do we know about how patients feel about that term and the concept in general?
So asking about, and you can tell me if I didn't get this right, so asking about the patient's perspective on self-management. So do they look at it as a positive thing, or kind of being discounted and brushed off from the system?
Maybe there are also patients here, so they can also answer that question, of course. And I do work together with patients in different projects, and I think that patients really value and like the concept of self-management, but not as a replacement for their care. So that is also the reason that self-management is also about working together with your healthcare practitioner, and it's really focused on that, to have building a good relationship with your healthcare practitioner, and then it can be supportive. So I think that's very important. So not only about reducing costs and do it on your own, but obtaining that support. And I think really patients will value that, because also with regard to follow-up, and also for the next year, when they have recurrences or flare-ups or something like that, I think patients really value that you provide some support to overcome these barriers in the future. So I believe, and maybe if not, then raise your hands if you are a patient. Patients really like the concept of self-management if used appropriately.
Okay, let's have one more question in the room. Are there any more questions online? Or no, just the one? Okay, come on up.
So I came up here with a question, and unfortunately, or whatever, it's turned into a comment more. So Megan Doyle, occupational therapist. And this is where I think I might finally have the urge to get my PhD, because I think what the problem is, this is wonderful, and it absolutely needs self-management language, needs to transcend any and all healthcare disciplines and providers. But I'm just really happy to share that this is exactly what the scope of occupational therapy does in a nutshell. And we really integrate it into any and all populations that we work with. And I think maybe there's just some misconceptions or ignorance, or unfortunately, maybe my profession just isn't publishing in the right places, or that's just not being understood. So again, I just love this conference and love coming here and loving having that collaboration and learning from each other. Just again, would like to know, I know that you are coming from a different country, but if you have encountered or, see, there was a question. If you have encountered or worked with occupational therapists working on self-management.
Yes, so also in the Netherlands we have occupational therapists. I don't know if their scope of practice is exactly the same as here, and in the Netherlands we also have other practitioners like exercise therapists, for example. And I think we can learn from each other and also need to use each other. So work together with each other and also refer patients or work together with other professions on the patient. So I think that's very valuable. But in the Netherlands, I think the focus of the occupational health physiotherapist, is the scope of practice is different compared to the physical therapist. So that's the reason I also believe that also physical therapists should use such an approach. And I'm happy to hear that in your profession it's more often used maybe, and people are really working with that. But in the physical therapy profession, that's not always the case. So I think really we can learn from each other. So also good to have that connection and learn between professions, yeah. So thank you.
All right, well, thank you for another great talk.
Thank you.
Another round of applause.